Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. Summer is just around the corner and for many of us, of course, that means a lot more time in the sun. Sunburns aren't just painful, they can be risky. And quite simply, the more times you get sunburned, the higher risk you have for skin cancer. You know you should be wearing sunscreen, but we're going to test your sunscreen knowledge a bit this morning with a little quiz. The first question, true or false, all sunscreens protect against sunburn, but only those that are SPF 15 or above and are broad spectrum have also been shown to reduce the risk of skin cancer and early signs of aging. And one more question, and it's multiple choice. How often do you need to reapply sunscreen when you're outside? At least once every hour, every 2 hours, every 4 hours, or you don't need to reapply at all, or only need to reapply after sweating or swimming. We'll get to those answers here a little bit later in the update. To learn more about skin cancer, we're joined by two of our doctors here at the University of Kansas Cancer Center who both specialize in skin cancers. Right here in the center is Dr. Gary Doolittle, medical oncologist, and Luke Selby across from me. He is a surgical oncologist. Gentlemen, good to see you both.
Good morning.
Thanks for having
On this, is it Melanoma Monday? Is it May? That's kind of like what we kick it off.
May is Melanoma Awareness Month, Skin Cancer Awareness Month. Melanoma Monday is actually the first Monday in May.
That's right, May 1st. Okay, so we have one of their patients. So Mark Morgan was treated by both of our doctors here this morning. He was diagnosed with malignant melanoma, the most serious type of skin cancer. Mark, thank you so much for joining us. I know you're on vacation with your family, so thanks for getting up extra early on the coast for us.
Well, thank you, Jessica. Just appreciate being on the show.
Well, it's such an important topic, and so we're just glad that you're going to share your story with us. We know you were diagnosed in 2019. Just first, Mark, how did you learn you had skin cancer? Did you notice a spot? Did you see something?
Just real briefly, when I was young, I had a doctor as a father, so he got me into a dermatologist to check that. Ever since that time, there's been checks with dermatologists to check your moles. They do mole maps, and they also educate you on different types of moles. So in 2009, I noticed one of my moles on my stomach area, abdomen, what did not seem right from that. And so that was taken off. They surgically removed that, and everything was good. And then I kept with the different annual checks. And in 2019, as you mentioned, through the blood check and through some things, we found that some of the things weren't right. So I had a PET scan, and it showed that, the melanoma has moved or metastasized into my lymph nodes.
That must have been a complete shock.
When anybody gets to know they have cancer like that, then it is a shock. But really, some great teams there at KU, Dr. Doolittle and his team, and Selby and his team, really gave me the right information and my family the right information to approach us in the right way.
So you told us a little bit of your younger childhood history, and definitely having a physician father helps send you in the right direction with doing those checks. But you also spend a lot of times outdoors. You're an avid biker, and we snuck in on one of your little biking treks the other day. So thanks for letting us tag along. But you're outdoors quite a bit. Knowing that you were doing these checks all along, were you doing a good job of wearing sunscreen and protecting yourself?
I want to say I was, but obviously I would get sunburns at times, and then I'd get scolded by my wife on those. So, but I always tried to keep sunblock on my ears, nose, face, hands. So kind of the tips, and then try to wear more protective clothing on my arms. But I thought I was doing a pretty good job with that.
Yeah, it sounds like you were. I want to bring in your team, and let's start with Dr. Doolittle. Just what makes malignant melanoma, why is it so serious? When we hear melanoma, it's a scary word when we talk about skin cancer. So just tell us about what makes it so unusual like that.
Fair enough. I mean, melanoma is one of the three main skin cancers. We have squamous cell and basal cell, and those are very common, and many patients are familiar with those. And the good part about that, if you can say anything good about a cancer, is that you can surgically remove them, and the chances are very high, very, very high that they'll be cured. The trouble with melanoma is they have the capacity to spread from where they start to other areas of the body, and that's when it becomes a big problem, because up until the last 10 years, we've not had good treatments for melanoma once it had spread.
So when you first met Mark, what was the prognosis? What was he exactly diagnosed with, and how did you kind of strategize on where he was going to go next?
Right. I think with Mark's case, again, if you have to have melanoma, I think it's a lot better to have melanoma in 2019 than it was in 2010. If I had met Mark 10 years prior, he would have had about an 80% chance of that melanoma progressing and ultimately not surviving it. Now it's so hard to even predict prognosis for a patient, because so many of the therapies we have, immunotherapy, this is still very much a surgical disease, so that's why Dr. Selby and I work so closely together. We have new agents called targeted agents that help. So first meeting Mark, it was all about trying to get his disease under control with immunotherapy, but always with the intent that we had hoped to get him to surgery at some point.
Tell us more about immunotherapy as a treatment option.
Amazing. I mean, immunotherapy has actually turned the cancer world inside out. And the thing that's so amazing about it is these are drugs that harness the body's own immune cells, activates them, and it's those activated immune cells that go after the cancer cells. At this point, there are at least 14 or 15 different immunotherapy indications for different cancers. It's funny, I look at Dr. Selby because there was a time when a surgeon would know that much about what I do, and I certainly don't know what a surgeon does. Now he's more interested in immunotherapy than I am sometimes as we go back and forth with it, because the relationship has to be that close. We're both, sometimes you start a patient with immunotherapy and go to surgery, sometimes you start with surgery and go to immunotherapy, and that multidisciplinary team is just really important in the care of a melanoma patient.
Well, and like I said, it really benefits the patient having this open dialogue, and you've got everybody tackling it from every angle and talking about the case. Dr. Selby, what is involved in surgery for melanoma?
Yeah, so it really depends on the stage of the melanoma that you found. So most of my patients come to me after either their primary care doc or a dermatologist has found a mole and biopsied it, and that has come back as melanoma. At the very least there, we're going to be doing a wide local excision, which is taking out that melanoma and then closing the skin defect that I make. Depending on the depth of the melanoma, and most of my patients, we're also going to be recommending a sentinel lymph node biopsy, which is another procedure done at the same time, where we sample the lymph nodes in the part of the body that drains that. So we're going to inject a perfectly harmless radioactive dye and then a perfectly harmless colored dye around the melanoma. I'll find the couple of nodes in the armpit or the groin or the neck that have taken up that dye. Everything comes out, everything goes to the pathologist, the results come back in about a week, and then we know from there what else is involved. At the very least, by virtue of having melanoma, you're going to follow with your dermatologist very frequently, and you're going to follow with my team very frequently, basically forever. And then depending on the specifics, you're going to meet Dr. Doolittle.
So Dr. Doolittle, you're going to be the one who diagnoses with melanoma, because I want to find out really, a patient like Mark or any of us who comes, is there any buzzwords we should be hearing that would cause somebody to need a second opinion? Where does that come in? Because that's really what we're all about, that power of a second opinion.
Right. So most melanomas are really diagnosed either by the patient's primary care practitioner or a dermatologist. Having said that, many melanomas are first noted by the patient herself. So it's really important for patients to be aware of the moles they have, a skin mole that is itchy, bleeding, changing, something that's new, to be really aware of that and then point that out to their primary care practitioner or to their dermatologist. Once the diagnosis is made with a biopsy, then it really much more often goes to Dr. Selby, would go to a surgeon, or every once in a while, if we know that the patient has more advanced disease, they will come to see me first.
So Dr. Selby, different options. How do people know whether the option that they're being presented is right for them, or they should seek a second opinion?
The very specific version is if your depth of your melanoma is more than 0.8 millimeters, you should probably see a surgeon. Certainly if it's deeper than a millimeter, you should see a surgeon. But the real answer is if you think you should have a second opinion, you should ask whoever you're seeing for your first opinion if you should have a second opinion. You know, I do a lot of melanoma. I did general surgery residency and a surgical oncology fellowship to be trained to do melanoma. I'm on all of the national committees to discuss the treatment of melanoma, not only what we're doing now, but what should we be doing in the future. But if someone wants a second opinion, I'm more than happy to discuss who at KU they should see, or if they want to go to another institution, who they should see. And it doesn't bother me at all, because if it's what the patient thinks they need, then great.
As far as melanoma goes, was Mark's case pretty standard on what you see? Is there anything unique that stood out about his case?
I think the thing that stood out about Mark's case was Mark. He was amazing in the way that he approached it, and just 100% took it on from day one and kind of ran through the process. So I think that was really unique. As far as the medical piece of it, presenting with lymph nodes swollen like that is not rare. It's not the most common, but it's not rare. And we're used to dealing with that piece. I think something that has changed since then is that we routinely will start with immunotherapy in somebody that presents with lymph node disease like Mark did. And there was a time when we might have gone to surgery first and then come back with treatment. And Mark just actually came into it at a time when immunotherapy was available. And that's a good thing, because we found out through a national study that Dr. Selby and I participated in that starting with immunotherapy in patients that present with lymph nodes that are swollen is actually an advantage. So his timing was great, but his approach to the disease process and getting through the therapy was inspirational.
And what's involved in immunotherapy? Let's just jump on that real quick.
These drugs are given intravenously. They're given in the outpatient clinic every 3 or 4 weeks. Depending upon the type of melanoma, stage of melanoma, it can go on for a year or 2 or even longer. If you have widespread melanoma, it can go indefinitely. So what we do during that time period, we give the drug intravenously, but more as much, we monitor for side effects of the drug, because immunotherapy goes after immune cells and activates them, and so it's activated immune cells that go after the cancer cells. But part of the problem is sometimes those activated immune cells go after healthy cells, and that's when we see side effects with immunotherapy. So part of it's giving the drug, and a very important part of it is monitoring for side effects that we see. Dr.
Selby?
Yeah, I think the other thing that's unique about Mark's case is it happened at a very interesting time. If he had been diagnosed in 2009 instead of 2019, we wouldn't be here having this conversation. And if he was diagnosed in 2029, the treatment will be totally different, because, as Dr. Doolittle said, not only are we using immunotherapy in most solid tumors, but we're on our 3rd or 4th generation of immunotherapy, and we have new stuff in trials that we're participating in, but we also have new drugs that 2 years from now are going to be in a trial that we don't even know about yet. And so it's changing very, very rapidly. And 5 years ago, no one would have expected being able to have this conversation. 5 years from now, probably it's going to seem a little bit anachronistic, because we're going to have some other science fiction that we don't know about.
A really exciting time is what I hear you say.
Exactly.
Let's talk about sunscreen, sun protection. We can't have this program without doing that. What is broad spectrum? Help us understand. When I go to the drugstore, I'm standing in front of 50 different types, different brands. What am I really looking for when it comes to ingredients? What really matters?
Right. So when we talk about a broad spectrum sunscreen, it's a sunscreen that takes care of both UVA radiation and UVB radiation. Without getting too technical about it, the UVB radiation is really probably the bad actor when it comes to developing skin cancers, and in particular melanoma. UVA, we think, can result in skin cancers, but more likely it's UVB, or the greatest contribution is UVB, but UVA really causes sun damage as well. So when we talk about a broad spectrum, it covers both. I think the most important take home, and we'll see what Dr. Selby says, but the most important take home is an SPF of 30 or greater. Try to avoid the sun from 10 to 4 if you can. That's not realistic, so just when you are out in the sun from 10 to 4, protect yourself. Sunglasses, hats, sun protective clothing.
What's your routine, Dr. Selby?
So this is what I tell patients. I have the hairstyle that I have and the skin type that I have. I'm a runner, I'm a cyclist, I have little kids, so we are outside all the time in the summer. And it's SPF 30 or greater, applied in the morning, which we've all been pretty good at for a while, reapplied every 2 hours, which the Selby family still has room to improve on. But we're here talking about melanoma and skin cancer. We just played a video of Mark on his bike, and he's not going to get in trouble because he was doing everything right.
Yeah.
You know, he had sunscreen on, but he also had long sleeves. He had a helmet, so he's protecting himself. You know, I have my job, and I have my hair color, or my hair black color, and skin type, and in the summer I drive a convertible, but I drive a convertible wearing a big hat, and I have sunscreen in my car. And so, you know, you're allowed to go out and live your life. You just have to protect yourself, just like I wear a seatbelt.
Right.
Just like I brush my teeth and all of these other things we do.
To protect your health.
Exactly.
Yep. So, Mark, what's the future look like for you? How are you doing, first of all, and how often do you see your oncologists?
Yeah, you know, I'm doing very well. I did not have a lot of side effects from the immunotherapy, a few, but I kept active, as you can see, biking, running outside. And right now, with Dr. Doolittle and his team, we have maintenance, 3-month maintenance, scans, blood, and checkup, so we can keep on top of this. And obviously, if I go outside wearing the sunscreen and protective clothing is vital now. Sunglasses, as Dr. Doolittle mentioned, and hats. And so that is my plan, is to keep with the maintenance of the scans, to keep protected, and to keep living. So.
Good. Keep out there. Stay on the bike. Just do it. Be smart about it. So you'll see Mark from time to time. He'll be your friend.
We will. Yeah.
So
every 3 months.
And any chance? Yeah. What are you looking for, though, just to make sure it doesn't come back?
That's a good question. We're actually looking to see if it does come back, and part of the reason we're looking is the things we can do to intervene. There are other treatments that we can employ. There are surgical approaches at different times. And so it's so important at this point to actually scan and look for recurrence. There was a time we didn't scan because there wasn't anything you could do if you found a recurrence. We're in a very different place right now when it comes to melanoma. So part of that scanning goes on pretty intensively for 2 years, and then we start to back away and back off to 6-month intervals. At some point, Mark is going to get sick of me enough. He's going to quit coming to see me but once a year or so. He's nodding, yes. So.
Yeah. I doubt it. I think you guys are kind of bonded for life, all three of you. So we want to share the answers to today's quiz questions that we asked off the top of the show. We ask, all sunscreens protect against sunburns, but only those that are SPF 15 or above and are broad spectrum have also been shown to reduce the risk of skin cancer and early signs of aging. True or false? That answer is true. Our other question, how often should you reapply sunscreen? As Dr. Selby said, the answer is B, at least every 2 hours when you're outside. So just lather up. You can't do it enough. And you can test your knowledge even more by going online and finding the FDA sunscreen quiz. And be sure to ask your questions to our docs here on the panel on YouTube, Facebook. You can tweet us or email us at the Medical News Network. The info is right there on your screen. But let's get a quick check of our COVID count with Dr. Dana Hawkinson. Good morning.
Hi.
Hey.
Yeah.
Happy Monday.
Yeah, that's right. The active infections have gone up just a little bit. 31 total, but 18 active, 4 in the ICU, 1 on the ventilator. We'll see, hopefully, maybe over the weekend, some of them, some of the flags for active infections were not cleared. So we'll see. Hopefully this isn't a true increase, and we'll see how the next 24 to 48 hours goes. Hopefully we can get those active infections down a little bit.
All right, some questions about repeat COVID infections. When a person gets COVID more than once, as we know, so if COVID is going to be a seasonal disease, and we've talked about that, that means we could just get COVID multiple times, anytime. So how common is reinfection, and what are the risks of that?
Yeah, I mean, I think we do believe that this virus will stay with us, will stay in circulation for sure. It will become hopefully more seasonal like the other respiratory viruses, including influenza, and those other common cough and cold coronaviruses. How common? There's been a few studies looking at it. Obviously, there are all caveats to these studies, looking at the time frame, looking at those situations which people may be in or not, also mask wearing, things like that. But it looks like around 5 to 15% of people, or a reinfection rate. But I think you also have to understand that individually, some people that we know maybe have had it already 2 or 3 times. So what are the risks? Well, it seems like the risks of hospitalization seem to go down, and severe disease seem to go down, but there are caveats to that as well. But overall, those risks seem to improve. However, of course, if you have those chronic conditions like age, other immunosuppressive conditions, your risks are higher. The other thing is, what about long COVID? Long COVID seems to maybe have a reduced risk if you get SARS-CoV-2 subsequent times. However, if you do have long COVID and get reinfected, those could exacerbate symptoms as well. The other thing is, even though long COVID risks may be reduced, you can still have increased risk of having other actual medical problems, like heart problems, like diabetes, like kidney issues or chronic lung issues with each subsequent infection as well. So although severe disease and hospitalization seem to be improved, those risks, you do have subsequent other risks. So we know that it is important to try and understand which situation you are going to be in, and always practice those pillars of infection prevention and control. Obviously, wearing a mask is always okay, but wash your hands frequently, and try not to touch your eyes, your nose, and mouth, and most importantly, stay updated with your vaccines as well.
80 reporters with us today. Let's get to some great community questions. First one is from Mara. Mark, are you always on the lookout when it comes to spots on your skin? Are you more aware than ever? And how often do you go to your dermatologist to get that full skin body check?
So I go to a dermatologist once a year, and they do a full mold check. And yes, I'm very aware of. They tell me, okay, we're not going to take this mold, but let's watch it, or they will take the moles off right then. But it's an annual check, and it's an annual mole map. And usually I'm pretty aware of all the different areas that could be a little higher risk.
Yeah, I bet. You're on it. Courtney wants to know, docs, is it harder to diagnose melanoma in someone with darker skin? And if so, what's being done to improve that screening process?
It is. The flip side of that is that the risk is lower.
Right.
But the dermatology community over the last 5 years, 10 years, has realized that the risks are different, and their education is different. So the dermatology community is doing a lot of outreach to medical students and residents and dermatologists, and also primary care physicians, to remind everyone that while people with my skin type are by far the highest risk of getting melanoma, it's not the only risk. And
so if you've had basal cell or squamous cell, which I have had basal cell, does that put you at higher risk?
You're at higher risk for higher risk for developing melanoma. But having said that, your risk is still relatively low.
Why?
Right? Because the risk of the population as a whole, if we just take the country as a whole, is about 2%, and your risk may be a little bit higher than that. Now, if you had a personal history of melanoma, you've got a 5 to 8% chance at least of developing a second melanoma through life. Or if you're a child of a of a patient with melanoma, your risk about doubles. It goes from that 2% baseline to about 4%.
Okay.
So it's higher. It's like one of those things that you should be aware of, but not lose sleep over. Be aware of, monitor, get you your dermatologist.
I do
be
every
careful.
year. And when we get off this, every year, I think the last 2 years we've done this show on May 1st, I get off and I go and I make my appointment.
There you go. Be aware of it, but you don't lose sleep over it.
Okay, I won't. But I think I have Selby skin.
Yeah.
I do too.
We all do. We're all fair like
I
that.
have Selby skin too.
Does Erica wants to know, does anything besides the sun cause skin cancer, in particular melanoma? What part does genetics play in it?
Yeah, that's a good question. I think for melanoma in particular, there are some genes that are passed from parent to child that put a patient at greater risk for melanoma, such that when we take a family history, if there are multiple cases of melanoma in an individual's family, we will actually refer to a genetics counselor. And the genetics counselor will take the history, but most likely send off a gene panel to look to see if that individual has a gene that puts you at greater risk. It's really important to have that information because it changes how we follow a patient, and if it's a gene associated with a different type of cancer, we may do additional testing to monitor for other cancers besides just melanoma itself. So genetics can play a role in this. The vast majority of melanomas are sporadic, meaning they don't come from a specific gene that comes from a parent to child, but it does come from the parent in the sense that all of our genetic makeup is part from our moms, part from our dads, and there's that piece of it. Like our coloring that's the genetic piece of it,
right,
where we're all have that that we have to pay attention to.
Jean wants to know any ointments that can activate the immune system to attack precancers or basal cell cancers.
There are treatments for precancers, and there are medicines for that really fall within the realm of the dermatologist practice. It's not something that I would do on my own as a patient, but would do under the care of a dermatologist.
Yeah.
Sorry.
No, I completely agree. When the best ointment to prevent the chance of developing melanoma or any other skin cancer is sunscreen.
Yeah.
And the best sunscreen is the one that you like and the one that you're going to put on. So, like my wife and I, the stuff that I like, she doesn't like, and vice versa, because she doesn't like how my sunscreen makes her skin feel, and I don't like how her sunscreen makes my skin feel. So I've got my sunscreen that I put on, and she's got her sunscreen that she puts on. And if one of us forgets ours, we put the other ones on begrudgingly. But
you put it on.
We put it on, and again, the best sunscreen is the one that you're going to put on and then reapply.
Right.
And that's the piece, because if you go to the pool or you go to the beach at 8 or 9 a.m. and you put it on, that's great and that's wonderful and you should do that. But if you get to the beach at 10 a.m. and you're there until 4 p.m. and you haven't put it on,
yikes.
If it wears off at 2 hours, it wears off at noon. And that's when the noon to the early afternoon is probably when the UV rays are highest and when the risk is highest.
Another quick point with the sunscreen is I think some of us don't apply enough. So the general rule of thumb is about a jigger full of sunscreen. I don't know who came up with that, but I'm just telling you, about a jigger full will take care of you.
Just a good old-fashioned shot glass.
Good old-fashioned shot glass.
Because you're carrying one around in your purse or something.
Everyone has one, don't they?
Obviously.
That's what you're doing at the beach.
Exactly. Last question's from Joellen. And this is such a good question because this is my mother. Growing up in the 60s, many of those people went out, they just sunbathed. They had the baby oil and they were out there for hours. How are those folks in their 70s doing? Have there been any studies of just to note how these people fared as they look back and go, God, I wish I would have done it differently?
So the risk of melanoma has gone up every year since we've been tracking it. Some of that has to do with better surveillance, so when you look for something, you find it. Some of it probably is we have a generation that grew up not knowing that they needed to wear sunscreen and going for a really good tan. The conversation I have with patients is a lot of these patients come in with a lot of entrenched guilt that they've been, they did this, and they sort of get really embarrassed and they tell me that. And I tell them, A, I don't have a time machine, so I can't go back and fix it, and B, we didn't know any better. And so now, Dr. Doolittle said this earlier, there's no good time to get cancer and there's no good time to get melanoma, but if you had to pick, this year is better than last year, was better than the year before, better than the year before that. So we're making progress. You can't, all of us did a fair number of things in our youth that maybe we would revisit.
You know better, you do better.
Yeah,
Exactly.
and that was the culture of the 60s.
It was.
right?
Just a really quick question. I have to ask this, but Emily says she has a mole on the bottom of her foot that her PCP said that she really should specifically monitor. Are moles on hands or feet something you
Right.
really need to keep an eye out for?
Right, and that was one of the things when Dr. Selby was talking about people of color. I mean, there's a particular type of melanoma called acral that involves the hands and the feet. So a mole on the foot is one that I would probably be very careful with, and if there was going to be a question one way or the other about whether or not to biopsy, I would biopsy.
Yeah, never hurts.
Bob Marley died of melanoma on his toe that for the longest time everyone thought was a soccer injury.
Now, that's an interesting fact.
Person of color, the conventional wisdom, so to speak, was you can't get melanoma, and that's not right. It's just the incidence is lower, and it's typically it's hands and feet.
Know your body the way that Mark did. He knew something wasn't right and was doing his checks. Mark, thank you so much. We're so glad that you're doing well and that you're out there in the sun, doing it right, on your bike, staying healthy. Just before we head out, just what's today's takeaway?
From my part, I think, like Dr. Doolittle mentioned, the advancements in the immunotherapy are growing. So make sure you go to your dermatologist, get checked, and then if something does happen, just make sure you progress along the needed path quickly. And there's a lot of good treatments out there. So,
Mark, thank you so much. It was great meeting you. Okay, go back to your vacation. Or go back to sleep, one or the other. Okay.
Thank you all.
Thank you. Dr. Selby, today's takeaway, what's it going to be?
The summer, everyone loves the summer. The summer is a great time to be outside. It's a great time to go to the pool, get on your bike, whatever it is, and you can go do that. But when you drive, you put on your seatbelt. When you go to the pool, you go to a pool with a lifeguard. When you are out in the sun, put your sunscreen on, and then go out and have fun, and then 2 hours later, reapply it.
Sounds simple. Dr. Doolittle.
I would echo some of Dr. Selby's comments, but also skin cancer is preventable and melanoma is treatable. And if you have any questions or concerns about something that you've noticed that's new, itching, bleeding, get to your primary care, get to your dermatologist and have it checked out.
And I hear you guys say that, things are advancing very quickly, and so that's really good
exciting.
news. So thank you both.
It's really
Good to
exciting
see you. And thank you to all of our viewers today for being with us and all your great questions. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update. 2 decades of pain kept David Conway from a normal life. Then surgeons implanted a newly approved device next to his spine. I'm Jessica Lovell on the next Morning Medical Update. Pain relief at the press of a button. The science behind his spinal cord stimulator that reacts to his every move. Tuesday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stein's podcast. Now, everywhere podcasts are available.